Please welcome President of the Women's Forum of New York 2012 to 2013, Doris Meister.
Good morning, everyone. Welcome to New York and our 50th anniversary celebration. I've actually been a member for 30 years, 30 of those 50, and we just keep getting better every year. So we just finished 2 stunning panels featuring women leading technology. Now we're going to shift to another critical area, global healthcare, where women are leading us through significant challenges. In the 5 years since the beginning of the COVID pandemic, healthcare has undergone a significant transformation. Advances in research and technology have taken ideas from lab to patient faster than ever. At the same time, though, systems for healthcare delivery have come under incredible strain. And some say it has lost the human touch. Today, we have an amazing panel of women who are meeting these challenges and leading us through it. Please welcome Dr. JANICE CHEN, co-founder and Chief Technology Officer of Mammoth Biosciences. With Nobel laureate Jennifer Doudna, JANICE co-founded this company that develops in vivo gene editing therapeutics to transform patient lives. This genome editing technology was cited last week in a breakthrough for sickle cell anemia. And she's only in her 30s, so she has plenty of time to keep changing our world. Welcome, Janice. So next we have Dr. Angela DIAZ. Angela is the director of the Mount Sinai Adolescent Health Center and Dean of Global Health, Social Justice, and Human Rights at the Icahn School of Medicine. So among parents in New York City, Angela is very well known and a critical partner in helping adolescents and their families through that very challenging time in life. She now has a role as dean, which was created to address the profound healthcare inequities that exist around the world. She is a passionate advocate for the most vulnerable and is a member of the Women's Forum of New York. So welcome, Angela. So next we can welcome Dr. NOUR, Chair of Obstetrics and Gynecology at Brigham and Women's Hospital in Boston. And she is also the Kate Macy Ladd Professor at Harvard University. Dr. NOUR founded the world-renowned African Women's Health Center in Boston and received a MacArthur Genius Grant for this initiative. She is a past IWF Fellow and a current member of IWF Massachusetts. Please welcome NAWAL. And to moderate our panel, a leader with so many accomplishments in academia and government that she almost needs no introduction. Former Secretary of the U.S. Department of Health and Human Services, a past president of the Women's Forum of New York, a member of the Women's Forum of New York and IWF Florida, and a member of the Women's Forum Hall of Fame. Please welcome Dr. DONNA SHALALA.
Thank you, Doris. Thank you, Doris. It's really great to be here. Scientific breakthroughs are happening all the time, and some are really changing the way we look at disease, even at the genetic level. It is an age when high tech meets high touch. Before we begin, as a reminder, please submit your short questions, and I mean short, on the conference app. We'll get to as many of them as we can at the end of the session. Now let's look at what you had to say about the future of healthcare. We asked IWF members in our global pulse survey, is high tech or high touch more important when it comes to your health? 10% of you said technology is the most important. We intend to change your minds today on that. 61% of you said, I want a human relationship, and that's the most important. So all of our guests have innovated in different ways in different areas of medicine, but they have one thing in common. Your work is changing the paradigm from treating disease to preventing it. And before I start asking each of them individually questions about technology and the future of healthcare, I thought, since the last panel had an extraordinary candidate speaker who said that at 16 she had built a robot, and I wanted to see whether any of you had built a robot at 16. But I want to know how you started, how you got interested in science, because women in science, relatively new, though we've had extraordinary women who have won Nobel Prizes, but the percentage of women that are going into science now has much improved. Or more than half of medical schools are women now. So take us back to your 16th year. And if you didn't do a robot, what were you thinking about? Janice?
So I didn't build a robot when I was 16, but I got into science at an early age, and I've always just been fascinated by how fundamental science can lead to impactful technologies. And I recall specifically during my undergrad at Johns Hopkins, I had the opportunity to join a course called Build a Genome, where the vision was to build a yeast genome from scratch. So starting from individual building blocks, so really short letters of DNA, how we could stitch that together to power an entire living organism. And I think that, to me, was really the first realization that we could program biology, and since then, I've just been so fascinated by what we can do with biology and life.
Angela?
Well, I will take you back to 4 years of age. I spent my childhood in the Dominican Republic, and when I was 4, I had a major accident, and I was carrying a glass bottle, and I fell, and I ended up in the hospital. And that was the first time that I saw doctors. And they were so nice to us kids that ever since then, I said I wanted to be a doctor. I didn't know what it meant, I didn't know what it was, and you know, I'm passionate about medicine. I love medicine. But then as years went by, I also got into science. I decided to do a PhD in science and also public health. So I see medicine and health very broadly.
No, I did not build a robot or anything of that. And I think it wasn't science that drove me into the field. It was women's health and women's reproductive rights. And so from my early age, I really wanted to impact girls' and women's lives throughout the lifespan. And so I just didn't know how to navigate it, and so I started with science, and then I went to Brown, and at that point I shifted over and did more anthropology, sociology, development studies, international, trying to think about how do we really impact women's health and rights, and then I shifted and navigated back to science. So I wouldn't say I'm like a true scientist, but rather a humanitarian.
So let's start with some of our questions. Janice, your company is doing cutting-edge research on CRISPR. Can you define CRISPR for us and what the technology does?
Yeah, CRISPR stands for clustered, regularly interspaced, short palindromic repeats. There's a reason.
You want to repeat that?
There's a reason why we call it CRISPR. It's a lot easier to remember and say. But what you should know is that CRISPR is one of the most important biotechnological breakthroughs in our lifetime. And it's because
By a woman.
By several women, actually, and many teams around the world. But this technology gives us the ability to program the underlying code of life. And that is a huge amount of potential, not just in healthcare, but in research, medicine, agriculture, and so many things that touch our lives today. One of the really incredible things about CRISPR is that it was first revealed to the world by two chemists, one my former PhD advisor, Dr. Jennifer DONNA, who's also my co-founder at Mammoth Biosciences. She's also a luminary in many aspects of the field, but also her colleague Emmanuel Charpentier. And together, they won the Nobel Prize in 2020 for this transformative gene editing technology. And just last year, the world saw the first approved CRISPR-based therapy for the treatment of sickle cell disease. So we really are just at the forefront of, thinking about new standards of care for treating genetic disease.
Thank you very much. We'll come back to CRISPR at a different point in this panel. NAWAL and Angela, you both are part of senior leadership at two of the largest and most respected hospital systems, healthcare systems in the United States. What would you say over the course of your career are the biggest changes to the operating and economic models for these institutions over the last 5 years, for example? Now, why don't you start?
Yeah, I mean, I think it won't come to any surprise that cost is probably one of the biggest headwinds and changes that we've been having to grapple with. And that impacts so many other things when it comes to healthcare. I have to say, having been in the healthcare system, I'm really proud of what we do in the US, but we could do so much better. And so as we think about the inflation of our cost and how much we charge, our reimbursements are also decreasing. And so there's this tension between trying to get providers to do more, but in fact their compensation is less. And so that creates a ripple effect. And I would say from a provider perspective, our providers are getting tired and burnt out. And so when they get burnt out, some of them are working slower, are just exhausted, or actually leave the workforce. And then on the other hand, I would say from a patient perspective, you may not be receiving the kind of care you might want from your providers. And as time goes on, so as the hospitals are dealing with this cost crisis, many of the academic hospitals are starting to shut down. So many of them are operating at a negative margin. Over 50% of them are operating at a negative margin, putting more and more pressure again on health providers. And then again, as patients, we're not receiving the care that we feel like we need to do, and our access has decreased. And so that tension is something that we really are needing to work on to try to bring and change our models.
Angela, when you're dealing with adolescents, this kind of tension is very difficult. I mean, if someone's looking over your shoulder and saying, you've got to move your patients faster, because when you're dealing with adolescents, the whole idea of moving them faster, particularly with your kind of holistic approach, must be a real challenge. Are you feeling the same things that NAWA's feeling?
You know, we were lucky that we were able to really, in New York City, develop a perfect system. We think it's a perfect system for young people. And what I mean by that is, and we have at any moment like 40,000 young people who are our patients. That meaning that we have seen them and they can continue to come to us because of their age. And we did it so that the clinicians spend as much time as that young person needed. And also, things are confidential and we don't charge the young people, we don't exchange money with them. And we were able to do that because of the generosity of New Yorkers, many of whom are here in this room. So we've raised the money to pay the staff, and they really, because with teenagers, 15 minutes visit is not going to work. You know, just imagine, I'm going to spend like an hour talking with them, getting to know them, what is really in their heart, what is really what they want, what are their dreams and aspirations. So you cannot do that in 15 minutes. But some of the other changes that I have seen in the larger healthcare, one is that for centuries, doctors and hospitals thought they were the center of the interaction. And finally, we are realizing that the patient is the center. So we are going from doctor center to patient center. We are also going from hospital-based to more ambulatory settings. And just to give you an example, Mount Sinai just opened a spine center, and they have their neurosurgeon, they have their orthopedist, they have their physiatrist. And now they are going to open a surgical center in the same outpatient facility, ambulatory. So a person with back problem can go there and get their medical services. That's what they need. If they need surgery, they can get it there. If they need also like physical therapy, they can get it there. And the other major change is that we went from one discipline providing services to multidisciplinary teams. And at the Mount Sinai Adolescent Health Center, we have 15 disciplines working together under one roof, integrated, to provide integrated services to young people, including medical, sexual and reproductive health, dental, optical, nutrition, health education, behavioral and mental health. I often say from head to toes, from mental to dental.
Now, that must sound like heaven to you, but there probably is some cost shifting that's going on in addition to philanthropy paying for that. How are institutions changing from a treatment to a prevention model? Because prevention isn't well reimbursed, as I well know. What's been the most difficult part of trying to shift?
Oh. I mean, I really like what you said, Angela. I think this idea of comprehensive and holistic care as we look at, I'm an OBGYN, so I'm going to say women, as we look at our women patients as they come in, we want to really think of them as holistically and not parse them out into organs or body parts, as I say. And so how do we think about delivering care that is equitable? And so, as I'd mentioned, I'm a humanitarian, so part of my lens is social justice and cultural competence and linguistic competence. And how do we think about every woman as she comes into our clinics or health centers, she's being taken care of in a way that is holistic, but also that there's no bias. And if it's a one-on-one interaction, the lens of bias increases because we don't know how we're seeing or perceiving our patients because we're so busy thinking about the diagnosis, and our patients don't know how we see them either. And so we've been trying to create these sort of structures or in policies to remove like structural racism, so that when every woman comes into our hospital, she's treated in the exact same way with these policies. But then we're all very different, and some people may speak English as a second language or don't speak English, and how do we provide the technology to ensure that they get that equitable care? And so that's where some of the technology, which is not very expensive, is iPads in the room so that interpreter services are available, or as you were saying, this comprehensive going into the communities, again, could be reimbursed, but doesn't take a lot of funds to have mobile vans so that we can provide the care that our patients need in the community. And this would be preventive care, so it's, blood pressure cuffs or checking for glucose levels, making sure that we either schedule mammograms. We're even trying to think about ultrasounds in these vans so that the patients don't have to come into the hospitals. And that's a sort of an innovative way that's not too costly. It's what we do. We're just doing it not in a big, high, academic medical center that requires a lot of overhead as patients come in. So we're thinking creatively about prevention, which we have always hoped we did, but we don't do very well.
And that's a touch. Angela, do you have any?
Yes, I'm also thrilled that we are going from a framework of treating diseases to a framework of promoting health using a prevention model and supported by a value-based payment model, meaning that before people were paid per visit or a fee for service, and now it's moving into being paid for value, for outcomes, so that is really great. But Sinai struggle, because Sinai believes in population health and is very committed to underserved community, but find that the economic model is not there to support primary prevention or the population health management. So we need to continue to really transform the healthcare delivery system until we achieve the ability to provide prevention and social services, because the population will have much better outcomes.
Yeah, and basically the reimbursement models haven't caught up with what we know we need to do to improve outcomes. Janice, I want to go back to CRISPR. Technologies like CRISPR are important tools for a prevention-based strategy. Despite how logical it sounds, this has met some resistance from traditional stakeholders in the sector. Where is it coming from and why?
Right, so if we zoom out a little bit and think, why is CRISPR so transformative for medicine? I mean, the genome, think of your genome as basically the Word document that contains the instructions for life, right? It is consistent of billions of letters of DNA, and sometimes those DNA instructions can generate some faulty letters that will result in genetic disease. And we now understand there are a number of diseases that have a real genetic basis, and understanding kind of what causes the manifestation of a disease is a critical component to what makes gene editing such a powerful technology, because now we have the ability to actually use CRISPR to permanently correct that underlying cause. And so, we have the ability to use CRISPR to add, delete, modify those sequences, and now it's not just a transient treatment, but really thinking about a cure. And certainly with the approval of the Casgevy, which is the CRISPR-based therapy for sickle cell disease, these patients now have a functional cure for their disease. So this is just, again, an early example. We're really in the early days of this technology, but now that we better understand the genes and how that contributes to our health, we have the ability to now interrogate those sequences and permanently change that. Now, one of the reasons why, well, there are several reasons why I think CRISPR has not been used as a preventative strategy. First, we have to prove the safety and efficacy in this medicine, and we are making a lot of grounds in doing so, right, with the first approved therapy, and now there are a number of experimental CRISPR trials underway. But I think there's other larger dynamics here at play, and Angela and NAWAL touched on some of those. But one is that our system does incentivize medicines that are administered throughout a patient's lifetime. I think the financial system really is able to, frankly, model those revenues over time, and it is the way our system is currently managing both reimbursement and also monitoring the growth of these medical products. But I think another piece too that we're starting to recognize is now we have the ability to permanently cure disease, and that has a profound impact on what it can mean for the future of healthcare. Right now, when we take medicines, we have the ability to stop taking those treatments if there are potential side effects. And I think if you have a CRISPR-based therapy, there's a potential to permanently cure that, and that means that it's a one and done therapy, and so that, again, will change the lives of patients living with these diseases, but that also means there's no going back. And I think these are real problems that the field is learning how to grapple, and there's a lot of work that's being done by many, many teams around the world, but the technology has to be proven to be safe, to be effective, and ultimately reach many, many populations around the world.
So now let's go back to this point, because we're talking about the economics and who gets paid for what. And this suggestion that we will move from treatment to actually a cure will take some money out of the system, basically. And so when we're talking about the stakeholders, they have a stake in how the system is currently organized, though I'm not questioning their morality in this, but they really do have a stake in a reimbursement system for treatment, particularly specialty treatment, and doing lots of things to the patient, because that's the way we've organized the economics of this. But your real suggestion, Janice, is that we actually will be able to cure some diseases. Sickle cell is an example.
Yeah.
What are the other examples that
Yeah.
you think are on the forefront?
So there are a number of ongoing trials. There are some examples of being able to use CRISPR to permanently manage lifelong levels of cholesterol, so really helping reduce the risk of developing cardiovascular disease in a patient's lifetime. There's other rare diseases that are being used where you can simply use CRISPR to change those sequences, and patients are no longer at risk for developing certain liver diseases. And there's a number of other examples. But fundamentally, CRISPR has a potential to displace entire categories of medicines, because now instead of taking, for instance, a lifetime course of statins, you can have a one-time genetic, cure for managing your cholesterol. So that's just one, I think, profound example for how this technology could really touch millions of lives.
And the two of you would have to reorganize what you do and what your colleagues do as a result of that.
Yes.
So I'd like to ask each of you, technology can dramatically change healthcare outcomes, but it's expensive. And how can we sort of navigate affordability and implement new technologies to get the best care? Let me start with Angela.
Well, I think technology is very important. And, but let's say in terms of the electronic medical record, I think it's a mixed blessing. It's really helping brought safety, because there are alerts that we have to follow. It tells us when to follow guidelines. And also, we have the entire history that is easier to find for the person, so you have more continuity. But the clinicians are saying that their documentation has increased to the point that it really takes over 50% of their time they spend documenting, and that leads to burnout. In terms of AI, Mount Sinai is actually using AI to identify patients who are at risk for malnutrition, delirium, risk of falling, and also risk of clinical deterioration. And because Mount Sinai is a top medical school and has many, many tremendous scientific resources, Mount Sinai was able to create this by itself, on its own. And they were able to do it, but most people really cannot have, because it's so expensive. So I think we need to continue to advocate for the right thing for the patients, and also for the right governance of AI within medicine and healthcare.
NOWA?
So I actually am trying to think about technology. Again, I always come in with a lens of sort of equity, but also how do we decrease cost? And so we have been doing more and more effort of trying to move patients out of the hospital. So when we think of charges, if a patient is being seen in a major hospital, they're going to be charged more. And the reimbursement will be according to a particular charge at the hospital. If a patient is seen in a clinic, the charge would be less, or even a community hospital, the charge will be less. What if we took care of patients at home? And so some of this home hospital efforts that we're really focusing on is, so a patient comes in, we'll actually talk to them about their surgery, so there will be treatment, but before they actually have their surgery, we'll send a team to their house to see if they have a good setup. The patient has her surgery, and then she goes home with a team who will be checking in on her a couple of times a day. That charge is so much less than if the patient was in the hospital being seen. And I would just ask all of you, would you prefer to be home recovering from your surgery? Would you rather be in a big hospital where you might be sharing a room with somebody and guests are coming in, and then the nurse is checking your blood pressure a bunch of times, and then there's a beeping machine, and then the IV just stopped? I'm just wondering, would you rather be home? And it would be cheaper. So how can we be innovative and creative and yet be very cost efficient? And that's one of the lenses that we're using. We're also trying to do home hospital as when patients come into the emergency department, they're seen by a triage nurse, and the nurse says, actually, we're going to send a team home with you right now. We're going to take care of you at home. Don't even come into the emergency department. That decreases infection rate, that it decreases all of the kind of costs that we think about. So we're trying to be creative, where we're still taking care of patients, but maybe in the right place at the right time.
Janice, a lot of people in the audience run businesses, and technology in healthcare is very different from technology breakthroughs in the corporate world where you might save money. In healthcare, it often costs you more money. How do you think about that issue?
Yeah, the cost issue is a very real one. I think in the example of the now approved therapy, the price tag is in the millions of dollars, and I think that's something that the healthcare system and our systems more broadly have to grapple with, because again, this concept of a one-time cure means that you're no longer having to pay for the cost of a lifetime of treatment, but all of that comes up front. And so I think the financial model has to change in how we actually pay for these medicines, and I think there's a lot of people thinking about this problem, and there has to be new ways of financing these kinds of medicines. I do think that technology is going to play a role as well in decreasing cost. I think, again, using this first example, it's a very, very complex procedure. It involves patients getting their blood cells removed from their body. Those cells are edited in a laboratory, a very controlled environment, have to be manufactured bespoke. It's a personal cell line that's being edited and manufactured, and then a patient has to undergo chemotherapy. Those cells are transfused back into the patient. So the entire journey can take up to a year, and also patients have to undergo chemotherapy in order for the transplantation to occur. So if you think about that entire process, yes, it is a functional cure. These patients no longer live with symptoms of sickle cell disease, but have to undergo this very painful, costly, very difficult journey. Now, if you think about where the technology is going, CRISPR will one day be injected into your body through systemic intravenous injection, and those molecules will be able to find the tissues where those edits need to happen. For instance, muscle diseases. CRISPR can now potentially go to the muscle itself and make those edits. It can go to the brain to make those edits to cure patients of neurodegenerative disease. And that is a much less complicated procedure. It's going to drive down cost. It's going to be easier to manufacture. And so all of these developments are going to come together to improve the patient journey and also allow us to have better access and ultimately affordability of these new medicines.
But the healthcare system would have to have a business plan in which they're prepared to invest on the front end in something that they haven't done because they've spread out the costs over
That's exactly right.
a period of time. Now, in addition to your duties as head of OBGYN, at Brigham, you've created a model for care that addresses women's, very important women's health issue that has global implications, female genital mutilation, FGM. Can you talk a little bit about your work and why you chose to focus on that part of women's global health issues?
I'm originally from the Sudan, so I grew up in the Sudan and Egypt, and the practice of FGM was very common and still is common in parts of Africa. When I came to the United States, I had wanted to continue global health work, but I also wanted to do the global, like being able to take care of patients when they've migrated or were refugees. So it's actually my 25th year anniversary this year, and we're going to be celebrating in about a month of opening the African Women's Health Center. And thank you. And we're so pleased. It's a safe space for women to come and be cared for their reproductive health. And we do reconstructive surgery for women who've undergone the more severe forms of FGM, but really providing a place for them to come where they don't feel judged and have a holistic perspective for them.
I think I'd like to go to some of the questions that we got from the audience. The first one is from Alana Mueller from IWF in Kansas. Let me read the question. Like many of us, my family is contending with generational healthcare challenges related to care and cost. What can families do better to prepare care for their aging generations with dignity while simultaneously preparing for our own wellness needs as we age? Boy, that's a big question. Who wants to? Angela? You deal with adolescents, but, you know.
I'm happy to.
Now I wanted to take that one.
So, you know, I had 2 aging parents over the last few years. Both have passed away with dignity. It is such a challenge because I feel like many of us are sandwiched, you know, where we have kids we're taking care of and also parents, and how to navigate that. I think it's really hard. You know, I would say the last 2 years have been really hard. And this concept, and even though I'm a healthcare provider, the importance of advocacy on behalf of your parents and their care is critical. And we want them to live the latter days of their lives with dignity, and we also want them to pass with dignity. And I don't think we do a wonderful job. I think we could do a much better job of caring for our elderly here. And so I think there's a lot of work to be done. It's a big question. I'm happy to talk more about it at some point, but I think there's so much opportunity to improve their experiences, to improve our experiences as their children, and then also to be able to navigate our careers as we are all managing that as well.
Angela?
But it's not just about the aging and the elderly. You know, when you look even low-income people in the US, in New York City in particular, who do not have health insurance, they do not have access to health care, they tend to have really poor outcomes, when indeed, if they get those services that they need at the right services at the right time, they will do very, very well. And just to give you an example, the young people that come to our program, they are US citizens. This is not about being an immigrant or anything like that. 70% do not have health insurance, and they have no access, but because they come to us and we see them, whether they are documented or not, whether they have health insurance or not, we don't exchange money, they do extremely well. The majority graduate from high school. Most of them actually go to college, and some of them go to graduate school. So they end up doing so well and then contributing to society. So it's at every step of the way that we need to really make sure that we have the access and we treat people with dignity and give them what they need at the right moment.
Yeah, there are a couple of financial issues here. Medicare will not cover home health care except for a short period of time when you come out of the hospital. And going on Medicaid doesn't work for people that are middle class or above the income limits. So, and the workforce challenges of who are going to be the home health care workers at the same time. When my mother passed at 104, she actually left money for her home health care workers to get nursing degrees. She was encouraging them. They had a lot of licenses, but she was encouraging them to actually move into the middle class by getting nursing degrees. And I'm proud to say that they all graduated from nursing school. And but the workforce challenge with immigrants, and even in New York, where you have more comprehensive coverage under Medicaid, and in Massachusetts you do too, it's still a challenge for people that are caught in the middle. I don't suppose CRISPR can help us with that. Anne Marie Dunn from IWF Canada, are there healthcare models in other parts of the world that are more advanced than the US model that could be integrated? That's a Canadian asking that. Do we want to talk about Canada?
I think Canada's great. I think I would say that we have a lot of lessons to learn from other parts of the world. I'll talk just about maternal care, and then, you know, hopefully you guys can pitch it. But I think from a maternity perspective, many of you may know that there's health inequities and there's a true maternal mortality crisis in the United States. Black and brown women are 3 times more likely to die of maternal mortality than whites. So we have the disparities. But also just our maternal mortality rate is so much higher than other countries. I'd say Canada does a great job. I'd say Scandinavian countries. And when we look at the data of why this might be happening, it has to do with, I think, the way that they provide care throughout the pregnancy, and then the postpartum period is so much longer. Their maternity leave is a lot longer than ours. And they have midwifery care, which is less costly, but also like really goes back to that first slide, which is really much more hands-on. We tend to be, as OB-GYNs, so clinical. And I'd say the final thing is that they also have doulas. So if not a midwife, they'll have a doula who's an advocate in the room. So when pregnant moms are just taking care of their labor moments, they have somebody that will help advocate and say, no, that's not what she wants, or she'd really like this. I think having a support person in the room is really critical, and we are working on this in the US, but we have a long way to go.
Yeah. And Angela, there are some models for youth healthcare focusing on adolescents in other parts of the world.
Well, I do global health, so I have been all over Africa, Asia, Europe, and I think that what we have here at Mount Sinai is not necessarily all over the US, it's really unique, even within the US. But people work very, very well in other places. For example, I think in other countries there's more alignment in terms of the behavior of the teenagers, what they are up to, and what the society recognizes and the services they're willing to give them. Sometimes I feel that in the US we are a little parochial in terms of teenagers. We think they should not be having sex. Therefore, we didn't want to distribute condoms in different places or things like that. I also think that the training that we get in the US as medical people is really, really excellent. It's TAPS. But I think that the planning or the distribution or access to healthcare is really poor. I have gone to many of the communist countries like Cuba, for example, and some of the design for the population really works well. And they emphasize there's more equity also because they look at the entire population. There's not such a difference. And we spend trillions of dollars in our healthcare system, and we are not even in the top 30 in terms of health outcomes. So that's a problem. And I think a lot of it has to do with equity and access and the planning, the design of the system itself, not the quality of healthcare or the equipment that we have. We are really top of the line when it comes to that.
Yeah. We had another question up there that I wanted to give to Janice. So could we get that question up as opposed to me winding up? Janice, look at this question. What do you think the potential for using AI to industrialize drug discovery, testing compound against multiple conditions rather than starting drug discovery focused on one condition? The question comes from Molly Burke at IWF in Georgia.
This is a great question. AI is going to touch on every single part of the drug discovery and development process, from making it more efficient to identify new drug targets, to being able to systematically address all the potential conditions that this drug could be used for treating certain conditions, to being more efficient at designing clinical trials, and ultimately even delivering the care at the end of the journey. And I think we see today AI touching on all pieces of it. It's gonna, it's not gonna overhaul the entire system in one go, but over time we're gonna see AI contribute to all these different steps along the way. And I think ultimately the goal is to drive down the cost and time it actually takes to get a drug to market. We know drug development is mired with failures, extremely costly, and anything we can do to change those statistics will make the world a better place.
Okay, let me, I have to wind up. We could carry on this conversation forever. I've learned a lot, and I hope all of you have too. Let me thank Janice and Angela and NOWAL for an extraordinary session and for their contributions to our health.